So Dr. Linda Goddard is a distinguished nursing professional with extensive experience in both Australia and the UK, specialising in mental health and the care of people with intellectual disabilities. She has extensive experience, including in hospitals and group homes and community services. Dr. Goddard's pioneering research, the Health Empowerment Learning Partnership model, focuses on addressing the unique health challenges faced by families with children who have disabilities. And Dr. Goddard has made significant contributions to nursing education, including undergraduate and postgraduate nursing programs, and integrating a focus on mental health and caring for people with intellectual disabilities. Finally, Dr. Goddard is a certified life coach and adopts a holistic approach to health and well-being, demonstrating her profound commitment to advocating for and enhancing the lives of people with disabilities and their families. So it's a pleasure for me to hand over to Dr. Goddard and to run through our session today, Building Connections. Thank you.
Thanks, Corey. Good morning. Good morning and welcome to everybody to the webinar this morning. Thanks for that introduction. I am passionate about the area of communication and passionate about working with people who have a wide range of healthcare needs, disabilities, mental health needs, whatever. And I think that our work, regardless of your role, always involves communication. It's important. It's really important that we get it right for the people that we work with who are incredibly vulnerable, but also for ourselves, because when we don't understand the people we work with, whether they are the clients or even our colleagues, then problems can occur and that can make work seem a little bit impossible at times. So we're hoping that today will give you some insight into some ideas around communication that can help you in the future. Connection is the energy that is created between people when they feel seen, heard, and valued, when they give and receive without judgment. I think that's a really important quote. So, communication is a fundamental human right. The United Nations Convention on the Rights of People with Disabilities say that people with disabilities have a right to access information in the way they need it and to be able to say what they want. Difficult when people can't actually talk, but there are other modes of communication, and the best one of all is that kind of non-verbal communication. You can look at someone across a crowded room and you get a sense of how they're feeling, happy, sad, especially when it's someone that you know. If we can do that with people that we know, then we can learn to do it with the people that we work with. The NDIS Code of Conduct requires workers and providers who deliver NDIS supports to act with respect for individual rights to freedom of expression, self-determination and decision-making in accordance with relevant laws and conventions. And I think the biggest word that I think is important is respect. I think it's important that we respect each other, but it's really important that we respect the people that we work with. Respect them enough to find out what it is that they're trying to communicate to us and to ensure that our communication is the right kind of communication with that person. And a quote from Siobhan, "The times when I can't communicate are the times I am most vulnerable." And many of you have probably worked with people who may have challenging behaviour, who may be difficult to deal with at times. And they do say that the research says that most of the behaviour problems occur because the person is unable to communicate or to have what it is they're communicating understood by the people around them. And one of my favourite sayings is all behaviour is communication. It's our job to kind of work out what it is the person is communicating to us. Work that out and you kind of partway on the journey. So, common concerns in communication. Choosing words carefully. We often worry about saying something that might be inappropriate or offensive. Some people coming from different backgrounds to us may not understand the words that we're using. So we have to be really careful that we are using the right words for the person. And you can kind of pick up whether you are or you're not by their response, the way their eyes move around, the way they tense up in their shoulders, the way they have a look that says, what are you saying? Or, oh, what was that? You know, we need to pick up that stuff. Misinterpretation, fear of misunderstanding the person's words or actions. I think for many of the people that we work with, and not only our clients, but also staff, people can be fearful of meeting someone new. And, you know, we might fear misunderstanding the person, but they equally are fearful of us and misunderstanding us. Building rapport, concerns about how to establish a genuine connection. For most of us, we think it's easy. We go in, we say, hello, I'm here to work with you, and off we go. But what if you remind them of their Auntie Jean, who used to hit them over the head with a rolling pin? No, they're not going to like you straight away because they think, oh my goodness, you're like my auntie who was abusive to me. That's not your fault, and you can't say to the person, get over yourself. I think it's important to recognise whether you have a rapport with a person or not. And if you can't get a rapport, and I've often found in clinical situations, not often, I've found in clinical situations where I've had that person that I know that I can't get a rapport, I will swap with someone else. I will say to my direct supervisor, look, I can't get a rapport with this person. And when you have to do, you know, personal care with someone, what you need is a rapport. If you can't get that, if you haven't got that, then how can you start to move ahead in the relationship and to do different things with them? Personal boundaries, people are uncertain about, there is uncertainty about respecting personal space and boundaries. And there are rules around personal space. Some people think it's okay to walk straight into your personal space and stand right close to you, right up close to your face. It is not acceptable. It is not acceptable at all. It makes a person feel really uncomfortable. And remembering that many people with intellectual disabilities have experienced abuse, physical, psychological, you know, sexual abuse. So personal space for them is really important. You can ask them about that. You can't say, what's your personal space? But there are rules around personal space. And we do have to maintain, you know, a space between us and the person when first meeting. And then to ask it when you have to do things like lifting, moving people around, it's important to say, you're okay with me doing this. Reactions to mistakes, anxiety about how to handle situations when communication goes wrong. That's quite a common one, and we all get it. You know, like we are first and foremost human, and what do they say? To err is human. So we can all get it wrong, but it's how we handle the getting it wrong that matters. So I'm sorry, starting again. Concerns about managing personal emotions during interactions. I was always told when I first started nursing that you're not allowed to cry in front of patients, and I disagree with that. If I'm nursing a dying patient, or somebody has had some incredibly awful grief, news about someone dying, you know, then I may weep. I'm not over emotional, I don't burst into tears, but I may find myself weeping when holding the hand of someone who's going through a really bad time. Asking for clarification, hesitation to ask for clarification, fearing it might be rude or intrusive. It's important to ask for clarification. Again, I often think it's not what you do, it is how you do it. It is the way that you communicate with people. Adapting the communication style, changes in adjusting communication methods to suit individual needs. Most of the people who require a service from an organisation, in my experience, should have a kind of file that would give you some information about their communication style. Some people have a one-pager in their file. It does depend on the organisation, but good organisations would have a a one-pager at the beginning that sort of says, you know, this is a bit of an overview of the person, and this is their style of communication, or the communication approach that is used. So if they use symbols or Makaton or sign language, if they have a hearing impairment but can hear you if you face them with a normal volume. If you yell at someone who's hearing impaired, it's offensive, because it's often that that if you face them and you speak clearly, they will hear what you're saying. When you yell, you'll see their faces kind of go like this because it's offensive. So, but often people think all elderly people are deaf, so they yell, and all people with a disability are deaf, so we yell. All people from other cultures are deaf, so we yell. And all of you probably know that that's not in fact the case. Encouraging participation, worrying about how to encourage dialogue without being pushy. I often talk about the therapeutic use of silence, and Corey will remember this clearly in the classroom. Allowing a person to talk to you in their own time and sit in the comfort of silence can be incredibly therapeutic. The person needs to know that you really want to hear them, because often people with disabilities are talked at, but no one actually wants to hear their answers. So important to actually sit with them, to ask something or to say something, and to then allow the person to feel that they are worthy of being heard. I think that's a really important one. Okay. Levels of communication: interpersonal communication, which is one-to-one interaction between carer and another person. Most frequently used, lies at the heart of caring practice. Different opinions, experiences, values, and belief systems, and you need to validate and mutually negotiate meaning. When somebody doesn't understand what you're saying or has a different opinion to you, they're not wrong, they just have a different opinion. That talking with each other and hearing each other is really important in order to come to a mutually agreed approach to move forward. It results in the exchange of ideas, problem solving, expression of feelings, decision-making, goal achievement, team building, and personal growth. I've worked with some fantastic teams over the years, and we all get it wrong, and you know, we all can disagree, but it's a respectful disagreement. And I think, again, the word respect is at the forefront. Intrapersonal communication, that's self-talk, self-verbalization, self-instruction, inner talk. Some people may not do that. A lot of people do that. You know, you're kind of getting ready for whatever it is you're doing, and you kind of, like me before coming in today, talk to myself, you're going to be okay, Linda, it's okay. It's a webinar. Haven't done one of these for a long time. It's okay. People's thoughts strongly influence their perception, their feelings, their behaviour, and self-concept. Carers need to be aware of nature and content, of the nature and content of their thinking, and try to replace negative self-defeating thoughts with positive assertions. If we go into a communication experience thinking that we're not going to do so well, with a negative attitude, feeling angry, then we're probably not going to do very well. But if you kind of prep yourself and remember to breathe, and it's going to be okay, I've got to start somewhere, then you will find that it actually can work out okay. We just get really scared. The nature of the human being. The communication process, or communication, involves a sender and a receiver, and it has to have a message. It needs to be encoded and decoded, but the message itself can be influenced by a lot of things. You're always going to have feedback, but noise can really affect the message. Noise in the background, especially when you think about some of the people that we work with. I talked to a lady yesterday who was telling me that she just got a diagnosis of ADHD, and she said that her workplace was terrible, because if she had 3 people working, making a noise in the room, talking, it really affected her work. So she wore headphones while she was working to just cut out all that noise, because she related to the ADHD. It just meant that she heard all the noises. She's now started on a medication, and she said the noise has gone from 10, terrible, to 2. That was one of the most significant things that she experienced. I had never come across that before, but it just, again, it feeds into the repertoire I have around communication. We don't know what someone else is hearing or experiencing when we're talking to them. And some people, when you look at that inner voice, some people hear their inner voice continuously, even when they're receiving a message. So really important that we kind of tune into that stuff. It's not that they're wrong. It's not that they're awful. It is that people are impacted by many different influences, including their disability or other diagnosis they might have. And I think this includes staff as well as the clients that we work with. So basic elements of the communication process. The referent motivates a person to communicate with another. Sender encodes and delivers the message. The receiver receives and decodes. The message will be verbal, non-verbal, and uses symbiotic language. Interpreted by a personal perception. Same message, different interpretations, affected by education and experience. And there it goes via different channels, which are the means of conveying and receiving messages through visual, auditory, and tactile senses. You know, if someone is talking to you in a calm voice, but they're gripping your arm really tightly, it's sending a different message, isn't it? They can say that, oh, I feel good today, or I feel great today, but different messages. Same thing, different messages. One is more aggro, one is quite calm. Yeah. Feedback, we need to ensure that the message, or feedback is the message is returned by the receiver, that it's understood, verbal and non-verbal, and we need to clarify if necessary. And you know when you look at someone, and you send something to somebody, and you know whether they've understood or not just by looking at their face. The eyes are the windows to the soul, and they tell us often what the person is experiencing it. We can't tell what they're thinking because we can't read their minds, but you know, the eyes tell you, you know, if someone's uncomfortable, fearful, worried, concerned. Facial expressions says so much. The interpersonal variables are factors within both the sender and the receiver that influence communication, perception. Sometimes we're preconceived ideas about the person that we're talking with. And those preconceived ideas are influenced by other things in your life. And maybe that perception, preconception could influence in a negative way as well as a positive way. Being aware of that means that you tune into it and you kind of check yourself. The environment, the setting should meet participant need for physical and emotional comfort and safety. I think, I guess I often think about the bathroom situation. You're caring for somebody and you're intimate communication, and the person's in the bathroom, not wrapped around with a towel, they're wet or they're cold or they're, you know, and you're asking them things and talking away to them. You know, I mean, I think we should always be conscious of the environment for anyone, you know, and their comfort level. How do we communicate? Facial expression, eye contact, gestures, sounds, connotative meaning, personal appearance, posture, gait, pacing, intonation, clarity and brevity. So, sorry, that's an ambulance going by here. So saying what we mean and saying it in as few words as possible. Being very conscious that what we're saying to the person is going to be understood, that we don't want to have 6 or 7 questions when a person is not going to understand. You've got to one question at a time, and don't say too much in that question, but keep it to a minimum. If you don't know how much the person understands or they have an intellectual disability, less is best. I saw an interview the other day on television of a young lady with Down syndrome. She's been interviewed about dance, and it was on the weekend, and the reporter overloaded, and you could see this poor girl would have been able to answer a question, but to have 2 or 3 questions left her. She had her script that she would have responded with, but having too many questions really stopped her answering as clearly as she could have. Very difficult. Timing and relevance. There's an appropriate time for asking things or communicating in certain situations. How do we communicate? We often talk about zones of touch. So social zones, hang on just a second. Permission is not needed. We talk about social zones being the kind of hands, arms, shoulders. People can, you know, when you, hello, Mary, can I just ask you a question? You might pat someone on the arm. You don't need permission to necessarily tap them on the arm. But having said that, sometimes we have to be very careful. The consent zones where permission is needed, the mouth, the wrist, the feet. Vulnerable zones where special care is needed include the face, the neck, the front of the body. None of us would really like to be touched in those areas without somebody, you know, asking permission first, letting you know exactly what it is that they're going to do to you. You can't just go up to somebody. So when I first started working in the area in a group home, I'd see people just go and grab somebody's wheelchair and turn them around and move the chair. And I'd say, well, you can't do that. You actually have to go and let the person know what it is you're going to do. So, hi, Mary, we're going to go out to, get the bus. Are you okay if I wheel you out now? If I take your chair, yeah? But to just take the chair when someone's sitting there, and you'd often see the person who had cerebral palsy go like this, automatically into kind of seizure movement and get really distressed and not picked up by the person, which is really quite sad. So we do have to be very careful about the things that we do. And the intimate zone, of course, is the kind of genitalia area in the rectum. And when we are doing personal care, we have to be incredibly sensitive. And some people, unfortunately, if they have been abused, will be very scared when we're doing that kind of stuff. So I think we have to use a very gentle approach. And that comes across in the way we talk to somebody quietly. I'm just going, you're happy with me to do this. We're just going to clean you out, and, make you feel more comfortable. And yeah. Symbolic communication is obviously using symbols, different communication modes. Meta communication is communication about communication, the feelings and ideas that people are commenting on, what is involved in that communication. Contextual factors influencing communication, the psychophysiological influences, how physical and psychological states affect communication. If you've got someone who has mental health issues and they've got the voice talking in their head, and when I say the voice in their head, it can often be their own voice when someone's really anxious. So if someone is incredibly anxious and you're trying to talk to them, they may not hear you. The other really interesting thing is they may not remember what you've said. And I often say to the people that I work with who have high anxiety, and they say, I think I'm getting dementia because I don't remember anything. I can read a page and I can't remember what was on it. And I'll say, that is incredibly common with high anxiety. So we're going to work on your anxiety and you'll find you'll start to remember stuff a lot more. So a lot of staff will say, I just told you that. you know, I just told you about that and you're asking me about it again. And I'll say, please don't do that. You know, like the person may not remember because their anxiety and the voice in their head is just there the whole time. So they're not hearing, not because they don't want to, but because anxiety has taken over. You know, if somebody is experiencing something like schizophrenia, and you know what, people with disabilities, intellectual disabilities, can also have mental health needs. If they are hallucinating or deluded, then they have also voices that they hear, or people that they see, or things that they see that you can't see, but they can. And that will also influence the way that they are responding. Relational dynamics impacted the nature of relationships on the interactions. So I talked about, you know, Auntie Jean hitting the person over the head with a rolling pin, but you know, some you know, some families, some workers can be very domineering, and that affects communication. And then, of course, if they get away from that person, but then they get another one, then that can automatically upset the person's equilibrium. Situational factors, there is influence of specific circumstances on communication. You know, where is someone living? Who are they living with? Who are the staff who come in every day? Do they have good shifts and bad shifts? Does a staff member in on certain shifts have certain things happening? You know, I think, and it's not ever saying, I'm not saying that the person involved in the interaction is wrong. It just could be that they don't have a rapport with the person. And I think I've seen organisations where they'll move the staff around all the time. I don't know that that's good. I think you have to have core people who really know their clients. But I think that if someone always has issues on their shift with a particular person, we have to make sure that we're not really upsetting that individual by putting the wrong person in there where rapport can't be built. But never using a blame kind of culture, because it's not about blame. It is about the inability to get a rapport because of something we may not be aware of. How do surroundings affect the exchange of information? If you've got the radio blaring or the TV blaring continuously throughout the day, and you're trying to ask a client something, and there's a noise in the background, or you know, someone's digging up the front garden with with something, or there's a crane or an ambulance, and you're not going to hear things properly. Yeah, people may have a hearing impairment and all those extra noises. In the situation earlier with the person with ADHD, these things happen. If we don't think about it, we don't see it, we don't notice it. Ignorance is bliss, knowledge is power. Cultural backgrounds, the role of cultural norms and values in shaping communication. Again, it's, you know, if you don't understand, if someone takes offense, if you've said the wrong thing, you'll pick it up by the person's facial expression, being able to say, look, I'm sorry, what did, you know, did I just say something to offend? Or, you know, tell me what happened there. You know, I think I might have got it wrong. I apologize. Can we just look at this a bit differently? Really important. Communication is not easy. It is not easy at all. Non-therapeutic communication. These are the things we have to be very careful about. You know, asking people personal questions. When we're in a caring role, we have to be careful that this person that we're caring for is not our child, not our sister, brother, not our friend. We are paid to offer care, and we are in a position of power. Now, the most important thing is that we get a rapport and we recognise our role, which should be first and foremost respectful. So we're not going to just go in and ask personal questions without asking for permission to ask a particular question, but then being careful whether you need to know that information. You know, like when we're filling in forms, sometimes we need information. Giving the person, you know, the rationale for the question is useful. Giving people your personal opinion. Do they want it? Is it therapeutic? Changing the subject when someone talks to you. You know, if someone's wanting to talk to you about something, You know, when someone says to you, oh, it'll be all right, now let's go and have some lunch, is really rude. It's really awful. It says that you are not worthy of being heard. You are not worthy of my listening to you. Whereas when you sit and say, okay, tell me what it is that you want to talk about. You may not know the answer. That's okay. The person will possibly work out the answer in their own heads as they talk to you. And just a little scenario I'll throw in here, which was one I learned from one of my students years and years ago, is that, and this is a sweeping generalization, so don't shoot me down in flames, but women tend to, when they want to talk about something, they tend to talk to then work out in their heads what's going on. If they're talking to their partners, a male partner, for example, the male will want to fix it. His automatic response in some situations, so it's not totally generalized, will be, okay, I've got to fix it. So he'll get the toolbox out and he'll just want to fix it. And it'll give her all these things that she needs to do to sort out everything. So this student said, his wife would say to him, okay, we need to talk tonight, but I don't want you to bring the toolbox. I just need you to hear me. And he loved that because it meant that he could sit there and just zip this up and listen and nod in all the right places. And then she would say at the end, thank you so much. I now know what I'm going to do. I now know what I have to do. Where another night she would say, or another day she would say, okay, we're going to have a chat tonight, but I need you to bring the toolbox because we've got to sort out what we're going to do about this. And I think that's a really lovely analogy for communication between people in relationships, because it respects that some women need to talk about it in order to resolve the issue and just need someone to hear them, while other communication times are about sorting out problem solving, sorting out what the answer is. So I think that's a good thing for all of us to remember. The automatic responses, how are you today? You're good, yeah. Coming from England to Australia, you know, g'day, how you going? And I'd go to answer once I'd worked out what the message was. But by the time I worked my answer out, they'd already gone, you know. Oh, good, that's good. You know, checkout checks. That's good, that's nice. And they never hear what you say. So you have to be careful about automatic responses. False reassurance, you know it's going to be okay. Oh, it's going to be okay. Get a diagnosis of some long-term condition. Oh, you'll be right. It'll be right. Sympathy. Sympathy is different to empathy. Empathy is about walking in someone else's shoes. Sympathy is just, it's a kind of false sort of, oh, you poor thing, you know. That's not a useful thing. Asking for explanations for behaviour is, again, not necessarily therapeutic. Approval and disapproval. Interesting. Defensive responses. Why are you saying that to me? Why are you saying that? Why are you doing that? You know, passive or aggressive responses. And arguing, really non-therapeutic. They don't help the person at all. And remembering, again, wherever you are in the position of power more often than not with the person with the disability, with the client who requires the care. Contextual factors. I did this one, didn't I? Oh, sorry. Professional communication involves courtesy, the use of the person's name, not love and Dal. I hate it when I go somewhere and they call me love. Oh, hello, Dal. How are you? Are you talking to me? My name's Linda. Don't call me Dal or love. Babe. Babe's another one. Fancy calling someone babe. Honey, sweetie, gorgeous. Crap. They have a name. The person was given a name. They may have a nickname that they give you permission to use, but really important to be professional. Privacy and confidentiality, really important aspects of the work that we do. Trustworthiness, the person does need to know that you are trustworthy. Autonomy and responsibility, and assertiveness. And assertiveness is very different to aggressiveness, as I'm sure you all know. Assertiveness is about using the I word. I feel uncomfortable in this situation. Not you make me feel uncomfortable, because the you word is aggressive. You make me feel uncomfortable. If someone's been really aggro with me and I'm feeling uncomfortable, I will say something like, I feel really uncomfortable when you're yelling at me. I get clients in my office who can be highly anxious and very loud. And I just ask them quietly to just bring the volume down, because it is, I feel uncomfortable with the really loud noise. And I can also say that I know that if they can bring the volume down, that will help bring their anxiety down. And it works in 99.9% of cases, which is really great. But it is a skill I've learned over time. So we're not automatically able to do this stuff. Okay, so therapeutic communication techniques are asking the relevant questions, providing information about why you're asking the question, being able to paraphrase, say back to the person what it is that they're saying, not parrot phrasing, which is repeating exactly what they said, but saying what they said in a different way to ensure that they understood. Yeah. Clarifying, asking somebody what they meant. Can you tell me what you meant by that? Focusing, so honing into something and focusing on a particular aspect of the communication to make sure that your understanding is clearer. Summarizing what the person says to just check for that clarity. Self-disclosing can be useful. Not totally telling the person your life story, but, like somebody might talk to me about a fear of something and I might talk about my fear of spiders, or that, if you lost, somebody's going through a grief process and, oh, yeah, I understand that I have lost, somebody and it is a very difficult time. And that can be a helpful thing for somebody to realize that you do know what grief is. Yeah. Confronting. Sometimes you have to confront if somebody's, behavior can be a bit challenging. Again, it depends on your experience. Active listening. So showing that you're listening, really listening with your eyes, facing the person, looking at them, making eye contact, sharing observations, sharing empathy, sharing hope. People need to know about hope, especially when going through a tough time. Especially when they have, like Corey was saying earlier, degenerative conditions. It's not all about doom and gloom. There's also positive things that can happen. There's also hope about the way things move forward. Sharing humour, and be careful about humour. Some people use gutter humour, which isn't always appropriate depending on the person's background. Probably not appropriate very often, but, some people don't know that. Sharing feelings. Using touch, and we talked about touch earlier, and using silence. And this is, as I said earlier, this is a big one. The therapeutic use of silence is lovely. I would often just sit next to somebody and wait and see what happened, and sometimes you might sit for 5 to 10 minutes or even longer, and somebody then says something quite profound because you're sitting with them. And the sitting with a person in silence, I think, says to the person, you are worth sitting with. You are worth waiting to hear from. And it is lovely. And again, that's building upon that respect. 10 tips to improve the communication process. Use people first language. This emphasises the person first, not their disability. So this is an interesting one because people with physical disabilities will often refer to themselves as disabled people. People with intellectual disabilities hate that. They want to be seen as a person first. I, as a professional, will always use person first because to me, that says that I respect them as a person. They may say to me, I'd rather you call me a disabled person, or you refer to me as a disabled person. That's their choice and I respect that from them. But the safe place for me is to always use the person first approach. Don't assume. If you're not sure about something, just ask. Like, a lot of people think that everybody who's deaf is deaf at a certain volume. Everybody with a spinal injury has to rely on the person with them to talk for them because they can't talk for themselves, which of course we know is wrong. But, you know, you ask a person about what's going on for them. Speak directly to the person with the disability, not about them. Do not direct questions to the carers or others. It's really important that you ask the person. And it was interesting because I was at the shop the other week and I saw a client of mine with a disability with a different carer who I'd never met. And I'm talking to the client and the carer answered every question. Oh, that is so frustrating, so awful, so disrespectful. If possible, sit down so you're at eye level with the person. Speak in your normal voice. Again, that comes back to that yelling. You know, just because they have a disability, they're deaf. No, they're not. Talk to them in a normal voice. You'll know if they can hear you or not because they'll answer you. You can ask questions that can be answered with short responses, open questions rather than closed. Are you okay? Yes, no. How about how are you feeling today? They're more likely to say, I'm good or I'm not so good, yeah? Give the person time to process and respond. If you can't understand what a person is saying, don't pretend, just ask again. And if you don't understand, like when I work with someone with, like, I remember going to a conference once and I was talking to this guy before a particular session and he had cerebral palsy and some speech difficulties. And to listen to him was really hard, to understand what he was saying. And I just said to him, do you mind if I close my eyes and listen, because that helps me concentrate? And he was fine with that. And the interesting thing was that the next session he was presenting. And I just thought, wow, you know, and you just never know. People are incredibly capable, more than they're incapable. And pay attention to the non-verbal signs. You know, you can tell when you're with someone whether they're comfortable with you or not if you actually look at them. Body language, tense shoulders, you know, really tense jaw. It's really important that you look at those non-verbal things.